So first off, I want to welcome everybody to the panel. We are very excited for the discussion today with three outstanding behavioral health and measurement-based care experts. Dr. Scott, Dr. Resnick, Dr. Barber, we're thrilled to have each of you join us, so thank you. As well, thank you to everybody in attendance for taking the time out of your busy schedules to learn about MBC in SUD services. My name is Simon Weisz. I'm the president at Greenspace Health. We build technology that enables behavioral health and substance use organizations to implement MBC at scale. We're a mission-driven company that has now supported more than 600 organizations to successfully implement MBC. This gives us a front row seat to, I'd say, what's working and what's still hard across the sector. And today's conversation is one that we've been wanting to have for a while. SUD is one of the areas where we see the most opportunity, or some of the most opportunity for MBC to make a real difference. And the three experts joining us today are truly among the best in the field. So, without further ado, I'd like to jump into a bit of context setting. SUD care is evolving. There's growing pressure to demonstrate outcomes, improve accountability, and ensure consistent quality across programs. MBC is a practical way to meet that moment. Standardized, ongoing assessments to better understand how someone is doing and to guide care in real time. This is especially important in SUD services where progress isn't always linear, relapse can be a part of recovery, and consistent check-ins help teams respond earlier and support patients more effectively. At the same time, funders and other stakeholders are asking organizations to show that what they're doing is working, whether that's for value-based care, rate negotiation, grants, accreditation, or otherwise. Organizations that are getting ahead are building momentum and measurement into care right now, and that gives them a clearer view of performance and helps them improve quality in real time. So, with that context setting, I'd love to start with some introductions from our panelists here. So I'm going to go around in the order that I see everybody. So Dr. Kelli Scott, if you could please go first, then Sandy, then Jessica. We can sort of go in order there. Thank you.
Absolutely. So thrilled to be here today. I am Kelli Scott. I am a clinical psychologist by training and faculty member, assistant professor at the Center for Dissemination and Implementation Science at the Northwestern Feinberg School of Medicine. So I'm coming to you from Chicago, Illinois. Really thrilled to be here. My expertise is in implementation science and in specifically implementing and using measurement-based care clinically for both mood and anxiety disorders, as well as substance use treatment.
Hi, everyone. It is so great to be here again with Greenspace. I am also a psychologist, and I am a professor in the Department of Psychiatry at Yale University, and I'm coming to you from New Haven, Connecticut. And I'm also a co-founder, along with Jessica, of the Yale Measurement-Based Care Collaborative. And if you're familiar with either Greenspace or us from the past, you'll know that we have a history of collaborations and look forward to continuing today. My background is in psychiatric rehabilitation, but I also do significant work on implementation and measurement-based care.
Hi, everyone. I'm so happy to be here as well. I'm Jessica Barber, and I am also a clinical psychologist by training. My specialty is clinical health psychology. I have the pleasure of collaborating with Sandy in many ways. And when it comes to measurement-based care, my expertise is in the implementation, in the training, supporting clinicians, and I'm also a clinician myself, and I use measurement-based care in all of my clinical work.
Right. Thank you all. Now, I'm excited to just dive right into it. I know everybody is sort of here for the discussion, and so I don't think we need to set any more context at this point. So the first question I have really is to all three of you. Many of the people here are familiar with the impact of MBC in general behavioral health settings. I'd love you to speak to how it translates to SUD and what makes it uniquely important given the nature of SUD care.
Well, if it's okay, what I'd like to do before we do that is just sort of level set and make sure that even though we assume most people know what measurement-based care is by now, but just to make sure that we're all on the same page. So if you're new to the practice, don't worry, we got you right now. So measurement-based care is a collaborative clinical practice that can be integrated into any mental health treatment over time, um, or any mental health treatment. And we use, at least the way we define it, patient-reported outcome measures, or PROMs, to track progress over time, to increase engagement, and to collaboratively discuss goals and changes to the treatment plan. So Jessica and I have been working on the Collect, Share, Act model as a very specific model that has been developed by the U.S. Department of Veterans Affairs. And we've operationalized that and disseminated that as a specific model of measurement-based care. And we really, really emphasize transparency, collaboration, and using PROMs to pause and take stock of how treatment is going, which allows both clinicians and clients to get on the same page and to strengthen alliance. So very, very quickly, Collect, Share, Act, you collect measures, share measures back and have discussions about them, and then you do something with the measure. And we're going to undoubtedly talk a little bit more about that, but there's lots of information if all that is new to you to catch you up. And just overall, you'll hear us talking about the evidence for measurement-based care. And there is really strong research in psychotherapy in particular that measurement-based care improves outcomes, and what I think is really cool, decreases dropouts from care.
And I'd love to jump in, talking a little bit more specifically now about how MBC can support SUD care. And I'll focus on alliance as I do that. So, measurement-based care uses measures. And often I think the first thing that we think about, the most obvious option, would be a symptom-focused measure, or in the case of SUD care, perhaps a SUD-focused measure. And I certainly don't want to discourage that because these measures are really helpful in clinical and SUD settings. But I think measurement-based care provides a particularly valuable opportunity within SUD care. And this happens when, in addition to, or maybe even instead of, SUD-focused PROMs, we use measures of other things like quality of life or functioning. And so I frequently do this with a lot of the clients I work with. And there's one measure of quality of life and recovery that I love. And it includes domains like doing things important to the client or positive experiences like happiness. And what I love is that when we explore items and concepts like these, and as Sandy already mentioned, discussing and exploring the measures and the client's responses, that's part of measurement-based care. We have the opportunity to learn about intrinsic and values-based aspects of clients' lives. So this not only allows us to validate and affirm the person, but it really just aligns beautifully with a strengths-based and motivational interviewing style or approach. And that's obviously something that we know is really helpful in SUD care. And so, of course, the SUD specific outcomes are important, but there's just so much to every person we work with. And when we use recovery, quality of life, or these other kinds of measures, we can better support clients by tapping into these aspects of their lives. And then we can leverage what we learn. We can leverage that exploration to actually help their treatment. And then we also have an opportunity to balance some of these more SUD specific types of conversations that we know can feel difficult. They can sometimes feel stigmatizing, but we can balance those with conversations that are empowering and holistic.
And I really love Jessica's point about utilizing measurement-based care to learn about values-based aspects of clients' lives. And I think that this is particularly important in SUD care. So as I'm sure folks in the call are aware, and as Simon highlighted, recovery from substance use disorders is often not a linear process. And oftentimes when we're focused in on monitoring how someone's doing in treatment, we're thinking about that focus of supporting clients to either abstain or reduce use of substances. And that might result in us missing opportunities to really see how other aspects of our clients' lives are changing over time. And so assessing some of these other aspects or value-based indicators or strengths that our clients are experiencing can really allow us to see some of those subtle changes that may be kind of precursors to recovery. So maybe our clients haven't been able to abstain or start to reduce their substance use. But there are lots of other things that indicate that they're progressing, they're moving towards recovery as they define it for themselves. The other piece I want to highlight too is that measurement-based care and substance use treatment can also help with assessing for risk or potential risks for return to use, including things like overdose, which of course is crucial to monitor. We still are experiencing an overdose crisis in North America, and that is moving more towards opioids as well as stimulants. And so measurement-based care can be a nice opportunity to both see progress towards recovery as well as assess risks. And so it gives us a unique opportunity to align with a harm reduction as well as a strengths-based approach to care, where clinicians and clients can monitor multiple different aspects of a person's holistic recovery.
That's great. Thank you all. And I'll triple click on the point. Like I really love this idea of being able to ensure we think about measurement-based care more broadly than let's measure the use of substances. And I think that's how we get at sort of the value and the process value and the impact on guiding conversation, clinical decision making that is so central to the model. So thank you. There's increasing pressure on behavioral health generally, especially within substance use disorder systems, to demonstrate outcomes and improve client engagement. Yet adoption of MBC and SUD treatment remains pretty inconsistent. What are the most compelling reasons SUD treatment programs should be prioritizing MBC today?
I'll jump in and just say, I think first and foremost, we should talk about outcomes, of course. Measurement-based care is our systematic and repeated process where we pause, we look at how treatment is going, and we ask the important question, are we seeing the progress we were hoping for? And should we make some kind of adjustment? So fundamentally, or at the heart of it, measurement-based care provides that really valuable timely signal that tells us if something is off. And then a model like Collect, Share, Act is our roadmap for how to have those kinds of conversations in a collaborative way. When we're routinely taking stock of where we are and how that aligns with where we want to be, we just know we have a better chance of getting there.
And, in terms of value, we hear a lot these days about the overloaded mental health system and provider burnout. And one underappreciated aspect of measurement-based care for me is about how it really improves alliance and engagement on both ends of this dyad. So we talk about it as, tracking proms and tracking outcomes, but we've been focusing a lot, like I think over the last couple of months, we've been really thinking about measurement-based care as a way to stop and pause, that it provides an opportunity to stop to pause and think about how things are going and how that is so important. And that allows us the space to really understand the client's experience, to develop that alliance. And it's good for the provider too. We really hypothesize that this improves the provider's experience and potentially could reduce burnout in providers because they're having that basis of engagement and communication and collaboration. And it just helps us feel like we're more effective as providers as well.
I completely agree. And I think the place where I see measurement-based care being a priority for substance use disorder treatment is really that value that it adds to the clinician or counselor and client dyad. And so completely agree with Jessica and Sandy that it's especially valuable for providing those timely signals about progress, for improving alliance. And I think one thing I'll add is that measurement-based care can also be immensely helpful for clinicians who have very large caseloads, as well as somewhat limited time to meet with their clients. I work in opioid treatment programs where many of the counselors that I collaborate with have very large, even 70 or more clients on their caseload at any time. They're maybe only meeting with folks monthly for 30 minutes or less. And so in these cases, measurement-based care can be really helpful for aiding counselors and clients to efficiently get a sense of how clients are doing, quickly identify some of those core topics that you can talk about now today in that clinical session, assessing potential risk or lack of treatment progress to see, hey, do we need to make some changes to the treatment plan? Do we need to connect you to services? And also help you as a counselor keep track of client-specific needs over the course of care. I know for me, it's really hard when I'm seeing lots of folks and it's happening over a long period of time to remember, let's see how you're progressing from session to session when we have limited time together. And I also wanted to add one thing that we've talked about too is that, measurement-based care is somewhat underutilized in substance use disorder treatment, despite its potential to enhance that dyadic relationship as well as track progress. So we'll be talking a lot today about some of the things that get in the way of measurement-based care, as well as some of the facilitators that can help it move forward in this setting as well.
Great. Thank you. And I think, along the line of where you're taking us there, Kelli, of going from, I think, the higher level and theoretical and the values into the practical and what does this look like in practice. Would love to talk about some of the differences between implementation of MBC within SUD care versus general behavioral health. Right. And we already know, and we've talked about it today, MBC is not a one-size-fits-all approach. It needs to be flexible to different workflows based on care settings, and SUD settings have distinct clinical, operational, regulatory realities that need to shape implementation. So I guess the question here is what makes implementing MBC in SUD settings unique compared to other behavioral health environments?
Happy to kick this one off. My expertise is really in implementation science, and so I spend a lot of time thinking about context and how context is different in even within and across different substance use disorder treatment settings, but also across behavioral health care in general. And as you mentioned, Simon, there's a lot of different operational constraints, staffing and treatment models, as well as reporting requirements that exist in our substance use disorder treatment settings. And I bring a lens of focusing largely on opioid treatment programs, which of course are a little different from other contexts. But that's sort of what my lens is for this conversation. And I often like to highlight some of the challenges across multiple levels. So thinking about the system level, the clinic level, the clinician and counselor, and some of the patient level factors that might either make it a little bit easier or make it harder to implement something like measurement-based care in this new context. And I've had the great privilege of working with a wonderful team here at Northwestern, as well as the University of Pittsburgh School of Medicine and RTI International, on a set of research studies through our NIDA-funded center called the Healing Measurement Center. And one of the things we've done is really formally evaluate contextual factors that impact measurement-based care implementation. We're focused on the state of Pennsylvania and trying to get MBC implemented throughout. But we've worked a lot with treatment program counselors and leaders to get their feedback on what are the things that get in the way and what are the things that can help get this practice used, sustaining it over time. And some of the biggest things that have come up for us include things like the structure of measurement-based care. So what are the length of the measures? What's the content of the measures? Balancing it with other required paperwork and documentation. So of course, especially in opioid treatment programs, there's a lot of paperwork and documentation for administration of medication. Things like the cost of measurement-based care is always a major challenge that comes up. Organizational level buy-in, is there recognition and reward for using measurement-based care? And then making sure that it's a good fit for the client population. We have clients with co-occurring conditions, clients who may have challenges with technology. So thinking about some of those factors that may make clinicians wonder, for whom is this most appropriate? And although those things can sort of get in the way, I also want to highlight that substance use treatment programs have many, many strengths that can serve as facilitators to measurement-based care implementation as well. Things like positive beliefs about measurement-based care's potential to enhance care, strong and amazing communication relationship structures, both within organizations and across other recovery services in their community, and just a deep, deep commitment to supporting recovery. And so our team has really been focused on understanding this context, what gets in the way, what helps make measurement-based care work, and then being strategic about how do we actually approach implementation in this setting, and utilizing a lot of co-design approaches with our counselors and leaders and clients on the ground to make sure that it's a good fit.
Kelli, I'm so excited to hear about the work you're doing in this area because it is so, so needed. I mean, there just isn't a gold standard MBC model in SUD treatment. And we just need to be really clear and upfront with the audience right now that it we can't tell you do X, Y, and Z for this setting because the research, the practice just isn't quite there yet. Um, there's a lot of strong principles and strong evidence that we can draw from, and we know that we know examples of where it's working really well, so we feel very confident that it does work well. But you may need to be a little creative when you're doing this. And I just love Kelli's co-production and the collaboration idea and how it's just really important that you work together in order to figure out the right way to do this. So, like, for example, we don't have great data on how often measures should be repeated, what the frequency is. Although the clinicians we work with who find measurement-based care most effective just give them at every visit because it's part of how they just do treatment. And we have some evidence that there's a dose-response relationship, that the more measures you give, the better the measurement-based care works. But there's still, like in SUD care, I mean, people are complex. There's lots going on with the patient population. So there still is a lot that we don't know. I'm just thinking, I worked in a couple of different SUD settings when I was first starting out. We will not say how many years ago that was, but I've been in methadone treatment clinics, and I did CBT in a clinic with, I mean, talk about narrow, was young court-ordered male marijuana users, where I did measurement-based care as a really, really integral part of that practice. And I don't know how I would have done the practice without measurement-based care, quite honestly, because they weren't necessarily the most chatty bunch, and I would have a measure, and that would help us agenda set and figure out what module to use and how to really approach things. So we know that the principles are solid. We have examples of it working really, really well, but there are still so many complexities in SUD care that using Kelli's model of this co-production and working with your clinics, working with your populations, your providers in order to tailor the model for you is a great way to think about it.
Yeah, I really like that point. And I think generally when our team is thinking about measurement-based care implementation, you sort of always have to come back to this question of like, where's the value? Like, where is the value for the clinician, for the client, and what is the why behind why we're doing this? And I think the way that you're talking through that and applying it in this setting is really helpful. Um, now, in practice, our team, also often sees barriers and resistance to measurement-based care in SUD settings. And I think there's an element here where resistance to MBC is often less about the assessment tools and more about perceptions. And so I'm curious in everybody's perspective on how do kind of these preconceived perceptions, either towards SUD populations or towards measurement itself, show up during implementation? And how can organizations be proactive in addressing those perceptions?
I think for this question, it's important to note, substance use treatment organizations are often traditionally siloed from other behavioral health treatments. So many of our clients are coming to a opioid treatment program for treatment and then also receiving care across a variety of other services. And so as a result, there's lots of different substance use treatment models, but some may prioritize other types of treatment approaches, such as medication. And so there might be some questions about, if my program or treatment agency places less emphasis on counseling, or on therapy, how can I best fit measurement-based care into that structure that's very different? And I'll add too that clinicians and counselors in the SUD treatment space also have a wide variety of educational backgrounds. So in a lot of our work, we see about 50% of our clinicians have a master's degree or higher. Many are on the job working towards their licensure as certified alcohol and drug counselors. And so there may be a wide range of folks who have training in, how do you use patient-reported outcome measurement? How do you use data to inform treatment decision-making? What do I do when I find out that a client is struggling with a particular symptom? How do I act on that information? And so counselor training backgrounds may also have really important implications for sort of their readiness for measurement-based care, their understanding of data and interpretation, and knowing how to respond to either progress or lack of progress. And I would also really be remiss if I didn't highlight the role that stigma plays in the implementation of measurement-based care and how it's received in a substance use treatment space. So certainly there's both internalized stigma that we see in our clients, as well as stigmatizing beliefs that we've documented among healthcare providers, just given the history of substance use, given views on substance use over time. And then organizations also have substantive burdens, many of which have been historically rooted in stigma, such as heavily documenting care provision, having folks come in every day for dosing of medication, for example, as well as connection to other service structures that require mandated reporting of substance use, such as the criminal justice system if someone's on probation or parole. And so measurement-based care can then feel like an added burden or potentially even a system where you're monitoring the clinician or the client. And so clinicians might be reticent to use measurement-based care if it feels like they're being evaluated or their clients are being evaluated. And clients might be hesitant to disclose their substance use for fear of potential consequences, which have been really true in the past. Things like losing access to take-home doses of medication and having to come in every day, potentially even being discontinued from treatment or removed from a housing situation that's very valuable for their recovery. And so we're really in a different context here that we have to think about how we can frame measurement-based care as truly a clinical support tool and not something that can reify some of that stigma in this setting.
And really ensuring that organizations get that message. And, I've been working in program evaluation and data for a very long time. And, we always think really carefully before we collect data about how it can be used, but we can't not collect data because it can be misused. We just need to continue to educate people on the right way to use it. But just thinking about this whole clinician buy-in thing, I mean, even recently, I've been just continually reminded of how I think one of the biggest barriers is just a complete misconception of what measurement-based care actually is when you talk to a number of providers. So I just recently did a training a couple of weeks ago and, sort of checked and asked who already did measurement-based care. And then when I started talking about our model, somebody was like, oh yeah, I don't do that. Like, that is totally not what I do. My agency just told me I had to use the PHQ-9, so I gave a PHQ-9 and I thought I was doing measurement-based care. And I'm thinking, of course you don't like measurement-based care because that's not measurement-based care. That's just giving a PHQ-9 for no good reason. So I think when people start to understand that that this is a process that it integrates into care, that really empowers their clients to be part of treatment, and that it's super, super patient-centered and has the potential to make their work more effective. I think that just changes everything because of the misconceptions that this is somehow some cookbook checkbox requirement. And giving providers time and space to learn how to do it the right way can really, really reduce resistance.
Yeah, and so kind of like to highlight what Sandy's saying here about helping people see what measurement-based care can actually look like and how it can beautifully integrate with any work that we do. I would love to share a couple quick examples from my own work. So I mentioned a little while ago that I like to use a measure of quality of life and recovery. And there's an item that specifically asks about happiness on it. And last week, this is one of these like beautiful, surprising moments that can sometimes happen. I'm an MBC expert, and I am constantly surprised by how measurement-based care enhances my work. So literally just last week, a client told me that because they were answering that question every week, they now started to actually tune into small moments of happiness and joy just throughout their day. The fact that they knew that I was going to ask them about it made them think about it in their everyday life. And of course, I explored it and I learned more about what moments of happiness they experienced. But what I want to emphasize here is that this client spontaneously turned our measurement-based care question into this simple, beautiful practice that was having an impact on them every day. And I can't help but imagine how tapping into positive experiences could be really helpful for clients in SUD care. Another really cool example, this one's a little bit more clinical, but we can see the benefit of our treatments in real time. So I'm working with another client on anxiety and stress management. And one of the things that I typically teach right away is deep breathing and relaxation. And I'm using a measure that's pretty standard for anxiety monitoring, which is the GAD-7. And after teaching those tools, this client's ability to relax improved. And this person is experiencing more stress. There were a couple things on that measure that got worse, but we could actually see the benefit of their efforts. They were reporting benefit. The measure showed the benefit too. It affirmed that. And so they're more enthusiastic now about using this tool that's actually really helpful for them, even as they continue to struggle with challenges. So measurement-based care really is something we just fold into what we do and is highly personalized. But I think, as I've already, our colleagues have said here already, it's hard for people to envision that when they've not been exposed to a model like Collect Share Act.
Thank you. The next question here, I'll ask it to Kelli, and I think, especially given the experience with Healing Measure Center and implementing MBC in this sort of distributed implementation across OUD services. I think there's this common concern that we always hear, certainly, and I'm sure folks on this call are thinking around administrative burden. So MBC adds administrative burden. How can clinical leaders ensure that measurement feels and is clinically relevant rather than being an extra documentation layer without that clinical value?
And this is something our teams really thought a lot about and thought really strategically, and have come to the conclusion that I always come back to that co-design answer. I think that we can take a guess at what might work to reduce administrative burden, but it's really the leaders and the counselors and the clients on the ground who have the best answers for how it works in practice. And so some of the things we've focused on to reduce, the perception and actual administrative burden of measurement-based care is thinking about how do we integrate it into existing workflows so we're not adding parallel processes. This includes, co-designing the workflows, fitting it in a way that works well. And along with that, both co-designing the measures themselves, the selection of the measures, and how the Collect Share Act model is integrated, using data to inform conversations in real time. So making sure that measurement-based care is easily accessible. So if that's through technology, through electronic health record integration, or even using paper and pen, so I can quickly look and see what did my client say today on their measure, and I can just act in the moment. And then one of the things we're doing in the Healing Measurement Center is actually focusing on some de-implementation strategies. We are trying to de-implement antiquated or unnecessary or not required paperwork, maybe things that have come down the pipeline over the years and we've implemented them and that we just kept doing them because that's what we do. So we did a formal evaluation with our sites to say, what do you do now? What's actually required? And can we take away some of this so we can make room and time for measurement-based care? And that has been a really impactful step in reducing that administrative burden. But it really has to be proactive.
Great. Now we've got our next question here is around selecting measures in SUD treatment, and I'm kind of keeping my eye on the chat and Q&A on the side, and a few of the most upvoted questions are around this topic. So let's ask it now, and we can circle back in the Q&A as well. But I think this is clearly one that's on folks' minds. Um, given that MBC done right needs to be flexible to the service type and population being supported, and there's no gold standard approach for MBC and SUD today, how should programs think about selecting appropriate measures?
Well, I'll start by saying that for me, the most important motto is keep it practical. So I don't have any specific measures to recommend today, but just some ways that you can think about how to evaluate if a measure could be helpful. So we should remember the measures are tools. We have our total scores, that's a set of tools. And then those individual questions on the measure, that's another really important set of tools. And to me, those individual questions are really helpful because they're what allow us to drill down into specifics. So I always look at individual items when I'm deciding which measures might work well. I try to envision how could these questions lead to productive conversations, or are there items on here that, align with the kinds of things that you typically talk about with clients or that your teams talk about or that matter to the clients that you work with in the work that you do. Are there items that cover things that are important but maybe you don't ask about enough? What avenues of discussion could you unlock by adding in a particular set of prompt questions? These are some things you might consider when looking at different measures.
And completely agree. And to add to that, I think at the end of the day, the goal is to support clinicians and clients to use measurement-based care. And so finding a measure that is going to allow you to use it effectively is really the key goal here. And so there's not a one-size-fits-all solution. And in my work, both clinically as well as in research, we've actually explored a lot of idiographic or personalized assessment tools that can allow clinicians and clients to select, what questions should we ask, going back to Jessica's point, every session so that we can get a sense of what you care about most, what we're working on together, and make sure that it's really person-centered. So there's not a one-size-fits-all approach. It's really about selecting what can make measurement-based care work for you.
I'm not surprised that one of the most popular questions is what measures, right? Like, of course, people want to know what measure. That is a completely legitimate question, right? Tell me what measures to use. Um, but and I say this with all gentleness, it's really not the measure, it's, especially when you're new to the practice, you have this perspective that if only I have the right measure, everything's going to be great. I need this perfect measure that's going to be perfect for the reality is there is no perfect measure for pretty much anything. What's the magic is not the measure, although admittedly, the closer the measure is to what you're treating, to what people are interested, of course, that's going to generate the most valuable conversation. So you do want to, try to be in the ballpark. But pretty much any measure that's in that general arena is going to provide value when you share and act. So the magic is in the conversation, it's in the sharing, it's in the, listening, like Jessica's example of creating moments of happiness and reflecting on how that can enhance somebody's life. And just engaging clients in this process is what makes things so valuable and bringing your curiosity to everything. So I would just assure all of you, if you're thinking, okay, I'm new to this and I need the right measure, don't stress. Pick a measure, start and try the curiosity, try the share and act, and that's going to help you start with measurement-based care.
Yeah, I think that's helpful. And as you'd imagine, like our team gets that question a lot. And I think it is really important to like, as a kind of a sector to continue emphasizing the point that what we understand is the value of the process, the value of using measures that are relevant, that your clinicians see value in, and that are aligned with your client's goals, but not to focus so much on picking the perfect measure. And certain like our team is happy to support and share like this is what we see used in practice. These are examples, but I think you're getting the message from the experts here that it's probably less helpful to put a list of measures on the screen than it is to really talk about the process and the Collect Share Act model. So thank you. Um, Now, we had a goal of getting to the Q&A at the 45-minute mark. I have one more question I'd like to get to, but fortunately, it is also the third most upvoted question in the Q&A. So we're now gonna officially say we are jumping to the Q&A on time, and I'm sort of bring this kind of question to the group around the sustainability and ROI of measurement-based care. And so the question in the chat is directed at Dr. Scott. Maybe Kelli, you can start, and then we can go around the room. But I'll use the Q&A question here. So curious as a clinical leader, the impact that MBC has made, and if you were trying to build a business case to implement MBC within a substance use disorder org, what benefits would you focus on from a quality and ROI perspective?
That is a really good question. And I think this sort of parallels this idea of how do we sustain over time. And so I think several of the key benefits that I would argue from a return on investment perspective is thinking about, using the full Collect Share Act model as sort of our core. So right now, a lot of our organizations, they sort of started at a starting place where they were using measures, doing collect, but not necessarily doing share and act. And so some of the things that we're seeing is with increased fidelity to measurement-based care, we see enhanced outcomes both quantitatively and qualitatively, especially with our counselors and clients reporting, that they're using these tools to identify when someone might need an increase in a medication dosage, for example, because they're experiencing withdrawal symptoms. It's helped to improve alliance and to figure out what can we talk about at this session today in a short period of time. And so I think a lot of the benefits that, Jessica, Sandy, and I have highlighted are part of the rationale for kind of here's what the return on investment is for the quality of care provided. And then I think from a sustainability perspective too, we then have to think about how do we sustain practice beyond just compliance or completion of a measure. And so I think along with that, the integrated implementation strategies that need to happen also need to be part of that conversation. And that includes things like continuous quality improvement, ongoing monitoring of fidelity, and other approaches that can help you say, this is working. Things like are clients engaging with it, and do they like it? Are they enjoying the process? And testimonials about effectiveness. What is the clinical impact on the ground that we see, even if we aren't looking at, a big fancy study or a lot of data at any given time. And so I think figuring out how to best market that, to whomever you're talking about, to say we need to sustain this practice because it can improve care quality, engagement, and optimally, hopefully, retention and care, which is a real challenge, especially in opioid treatment.
I don't have much to add to that great answer. I'll just say that I know that maybe an elephant in the room is aggregated data. I know that agencies understandably are interested in using aggregate data to better understand sort of on the program level how the services are working. But before you can aggregate the data, you have to have high rates of adoption by providers and clients before the data is really meaningful. So focusing on that return of investment with the client and the effectiveness of the services, I think is a really nice place to start using, the clinical use case, success stories, how measurement-based care helps clients feel more engaged. Then as adoption increases based on that clinical success, adding in responsibly aggregated data that helps you do quality improvement along with the right messaging, what Kelli was talking about before about some of the dangers of, how the data might be misused or misinterpreted, can really help to add more value.
And I'll just add that to me, sustainability is a sure thing when when you experience how measurement-based care is enhancing the work that you do. And I think finding opportunities for people to share those success stories, as my colleagues have already mentioned, I shared a couple already today, and those are literally just from the last week. And so I will sound very cheesy when I say I get more excited about MBC all of the time. Just this morning, I'm sitting with a client and we're looking at a beautiful graph that is showing their improvement. And there's nothing better than knowing that this person truly feels empowered and truly has that confidence that they've grown or they've had improvement. So I know I saw in the Q&A somebody was asking, well, what's one of the best things or the most important thing about measurement-based care? To me, it's that it's empowering people. And recently, this was last week, was working with a client where we were looking at a discrepancy between how they were presenting and what the data were saying. And so after I explained to this client how important it is to me to truly understand her experiences and how happy I was that the data helped us see that we weren't on the same page. The goal is we want to get on the same page. But the data helped us understand something really important. And her response was, thank you for caring. So to me, that's the best thing about measurement-based care. It's the way it helps us connect. It's the way it helps us build alliance. It's the way that it helps us empower clients that we work with. So when the benefit of a practice is as a parent, why would you not want to keep it up? So share those stories, share those little magic moments, as we like to call them, because when we can hear that from our peers, that's really, really helpful.
Right. Thank you all. And Jessica, thank you for also tackling another question in the Q&A. That was really well segued. Um, the next one I want to get to is from let's see, it's a little bit down the list, but I think ties in a few of the concepts that are being asked about, and I'll just jump into it. So, in a standardized, specialized MHSU tertiary care setting, from an implementation perspective, how do we refine the choice of instruments? Should there be program level measures or more individualized measures? And how much measuring can be too much? And I like the end of that question is, I think, particularly interesting to me.
Well, one of the things that I find is interesting is that when we have lots and lots and lots of measures in our library, people still gravitate to a small number of them. And so I don't think you need a ton of choices. I think that you need a decent number because tailoring is important. I was saying the measure doesn't matter that much, but it matters. It's that middle ground. But I don't think you need a huge library. If you're working with, a system that has a lot, then great. But you'll find that people do gravitate to a handful of measures for whatever reason. At least that's been my experience. And I think that also the how much measurement is too much question. I think when clinicians really fully embrace collect, share, act, and integrate it into their practice, it becomes a new way of practicing. It's not an add-on. It's not too much. Like, I think Jessica can speak really well to this. Like her client, I mean, she does this every week, and her clients fill out measures at every session, and it's just how they do care. And that's how I was trained. I don't think I could do treatment without measures. Jessica, wouldn't you agree?
I would. And in fact, I recently had a circumstance with a client where we were talking about maybe changing measures and stopping measures that we were using that were kind of showing a lot of stability, and maybe adding something that would help us monitor something new that would be helpful in inspiring some new directions. And interestingly, this client said, I would actually like to keep using the measures that aren't changing because it makes me feel very reassured that I'm stable. But they also wanted to add the new measure because they liked the idea of what it might inspire for them and the kinds of things that they might be thinking about and the directions we might take it. So this was a really fun example. Again, these magic moments where I was like, well, we could stop too and just, and they're like, no, let's just do all three. So I think it's really personal, and there certainly might be some clients who wouldn't feel this way. They would be very happy to just do one. But I think that I like Sandy's idea of having like a nice menu of options for clinicians and clients to consider. And I think some of this too, just when you're trying to make these decisions, if this is brand new, there's nothing wrong with approaching it from a like, let's look at this as an experiment. Let's try some of these. Clinicians, get your hands on them. You try this one, you try this one, swap, share stories. What did you like? What helped? What kinds of cool conversations did you have? This could be a way of helping people either pick favorites, or this may be a way for you as a team to think about which ones maybe are most universally beneficial. So I don't think that you need to go into this being like, I'm gonna set this up and I'm gonna know exactly the right way to do it. I'm gonna think it through and we're gonna just hit the ground running. Feel free to iterate and to try stuff, see how it works. And there's also nothing wrong with doing some measures at certain visits and then like swapping them throughout the course of treatment. Maybe there's something you do once a month. But I think that flexibility is important, and everyone here has the opportunity to figure out what will work for your setting, for your teams, for your clinicians.
And I'll just add, this sort of goes to that co-design idea, and it also sort of builds autonomy. Oftentimes when these systems are implemented, they're implemented from the top down. The organization says we have to start using this, but it doesn't give the clinicians then an opportunity to do some of that experimentation. So I love that idea, Jessica, of giving it a try, being able to change it up, having this be directed by the clinicians and clients, even if it is something that the organization is adopting as a whole.
And ask the client, did you like this measure? How did you
Mm-hmm.
like filling this one out? How did you like filling that one out? There's
Exactly.
nothing wrong with that too. Get their input.
That's great. And we're in our last few minutes here. Maybe one more question that's at the top of the list that I'd like to pose to the group, and we'll handle this one pretty quickly. Then we can jump to our thank yous and closing remarks. So Lance asked, ASAM level of care criteria is focusing on the likelihood of harm occurring as a key level of care indicator. Now the question is really what standardized measurement is there for the concept of harm? I think we could expand that out because I know we don't want to jump right into like here's a specific measure. But how, any of you want to talk to how we're thinking about measuring harm as part of this process?
Well, I will just say that I'm not aware of any measures of harm. However, I've had some conversations with colleagues recently where they think about how measurement-based care is a way of knowing if treatment's benefiting clients and as a way of helping to ensure that treatment isn't inadvertently causing harm. Because if we know that treatment is working, then we might feel confident that we're reducing the risk of harm. Um, if we're able to ensure that we're moving in the right direction, or pause from time to time to ask clients, how is treatment going? How are you feeling about this? That may be a way of being able to make adjustments before we get to a place where harm could be happening. So we may conceive of processes like measurement-based care as a way of avoiding harm, although I'm not aware of any ways of applying measurement-based care specifically to that topic, and maybe others here are.
I'm not either, but I also think that measurement-based care can be a really valuable approach for identifying and monitoring whether a client is in the appropriate level of care, given their symptom presentation, given, their responses to measurement-based care, and it allows you to track over time. So if you're sort of starting off in a certain level of care, you're outpatient, you're monitoring, and you notice that maybe symptoms aren't improving and a patient or client might benefit from a higher level of care, that can be an indicator. So similar to Jessica, less about, objectively assessing harm and more about using your clinical expertise and the information from measurement-based care to make a careful decision about level of care.
I'll just quickly add, I can't, in terms of measurement-based care, those responses were perfect, but just a reminder that not all measures are for measurement-based care, that there are also other assessment processes. And so I'm not familiar with that particular concept of harm assessment, but there may be other processes to look at too that are not quite related, that are not the same as measurement-based care, maybe more of an occasional screening as opposed to tracking over time, but certainly a valuable thing to assess.
Yeah. Yeah, that's helpful. I mean, we definitely see partners of ours using measures or questions within measures, looking at suicidal ideation and using that as a risk indicator. But I think well said. Like I mean, well said in terms of describing like how that applies to collect share act and the measurement based care model. So with that, firstly, I would love to thank everybody for taking time out of the day to join. I'd like to extend a huge thank you to Dr. Scott, Dr. Resnick, Dr. Barber, for all of the work that went into this session. And I would like to wrap on sort of one final question and one final thought from each of you. So what is one theme that you wish more organizations understood about applying MBC in SUD care?
I guess I'll go first. I would just like to leave folks with this. Measurement-based care is a practical, client-centered tool that enhances outcomes of care and the experience of care for clients and for staff.
I think I want to emphasize that measurement-based care is not about algorithms. It's not cookbook medicine. It's not about check boxes. It's a powerful clinical tool that empowers clients and can make treatment more effective.
I'll, with the last word, say that oftentimes a barrier to measurement-based care is time. We can't put more hours in our day, but I really am a firm believer that measurement-based care is something that can help us be more efficient and effective and actually save us time in the end, because it helps us check in quickly and see what our clients need most.
That's great. Thank you very much, everybody, for joining. And as mentioned, we'll follow up with a recording, but we hope everybody has an amazing day.